So what I wanted to do today was to give you an overview, maybe complete the overview that might have been started, and I know that your interests may not be primarily research-oriented interests, but I thought maybe by having this overview and then we could have a discussion of what are the elements, what is the experience of our registry that may be helpful for you in dealing with the challenges that you emailed me of addressing the acute mental health needs in the wake of October 7th among many affected populations. So also, I know you heard from Dr. Rosen, Rebecca Rosen. You met with Dr. Sandra Lowe. They're from the World Trade Center Health Program. They talked to you about PTSD and mental health, and you met with other people. So I thought to ask just at the outset if we could take 1 or 2 more minutes, if any of you wanted to share maybe a key takeaway, a key learning that you had from the summer tour, or something that you're expecting to get out of this session today. I think it's worth a couple of minutes. Does anybody want to mention anything that was striking from the study tour?
Well, I'll start, and then maybe others will pitch in. But I think a number of people in the group felt that setting up a dedicated registry is something that maybe we ought to be doing in Israel. Not exactly the same way, but when we did our summary of the whole 2-day visit, it was one of the things that the most people mentioned as potential follow-up. Others, please share some thoughts.
Hi, if I may.
Yeah,
Michal, hi.
Hello, Mark. Hello, everyone. I'm Michal Aron from the head of the health team at MJB. Things that I remember and took from the tour that we had is once that first of all that the needs and the treatment should be assessed during lifetime. It's not a matter of a few months or a year after the event, but things can any trigger can start new problems along the lifetime, and there are some problems that develop over aging, and so it should be assessed longitudinally. And second of all, that is something that I wanted to hear from you in this meeting, is that I wasn't sure, and I asked, and I'm not sure I understood the answer, but I asked whether the registry was analyzed not just in the aspect of what were the needs, but also the effectiveness of the treatment that was given. So whether it is something that you checked and assessed during the years.
Yes, we can touch on that, definitely, and the the longitudinal nature of it is a big part of the registries. Thank you.
Anybody else want to share some reflections? It's been a while, but
I think I'll join what Bruce said. The fact that you have robust data over time, I think, overwhelmed us, and I agree with everything that was said here. I think what we are looking into is if we could do something following October 7th here in Israel. And I think the challenge here, and this is why I asked Joel to join in, and I'm so happy he's here, is how we obtain not only aggregative data, but really, and that goes to Michal's question, see what works. And this takes us maybe to a big challenge in Israel, not only in Israel, and how we do that. How do we obtain data and make it work so that we have it on a personal level? But we do have registries like that in health, but they're not interministerial registries. I don't know that we have these kind of things, and they're not on a personal level. Things that we do have in the CBS are obviously aggregative. So we are really interested in that. I'm really sorry not to see the education and the health ministry here, but we did have conversations behind the scene, the 3 ministries, and we're interested. So we have a good base maybe to collaborate on this issue. And how you did it, at the World Trade Center would really help us. Not the data, but the practicality of how to do this is something also on a political level would also help us maybe take forward similar action here.
Okay,
Yeah.
anybody else want to say some opening thoughts? Okay, Mark, over to you.
Okay, well, thank you for that. I missed the experience of meeting you all in person, and I just feel like I was there a little bit, having heard what you had to say. So let's, Natalie, you're going to move my slide. So let's move on to the first slide. And it actually relates to one of the comments we had. So first slide is just next slide is basically a snapshot of our registry. And can I have the next slide, please? Okay, so we are, we have a heavy research component to us. We are a longitudinal cohort study, 71,000 people who were exposed. They're followed over time. We get these periodic health updates every 3-4 years via surveys, but we have other data gathering that we do for research and surveillance. So we are matching to external data sources, governmental data sources, state cancer registries, state hospitalization, administrative databases, National Death Index, and we also match to the World Trade Center health program itself. And so when you met Dr. Rosen and Dr. Lowe, they were working for the World Trade Center health program, which is often confused with the World Trade Center health registry. And we do also perform more in-depth nested studies, clinical studies of selected subgroups of our enrollees, and that does include intervention studies, which I think may be something of interest to you all. And we, from the outset, were conceived as a platform for other 9/11 related studies by external academic researchers. It's a good way to extend the scope and breadth and depth of the work that we can do in-house. And the last element is really a core pillar of our registry. And we emphasize that we are involved in disaster response by facilitating the healthcare through the World Trade Center health program for enrollees and others that may be their family members who aren't enrolled in our registry. And this is a core for us because it shows we care. We can participate in health promotion. There's an existing program dedicated to treating 9/11 related conditions, and we can be a facilitated channel to that. Now, we are heavily research focused, but you could look at some other registry models. For example, I think someone was asking about the services. So there's a model where the registry is service oriented and facilitating the linkages of people to care. And a good model that comes to mind is the Flint, Michigan lead registry that was established about 6 to 10 years ago now. And their mission is to connect lead-poisoned children to educational services, to nutrition services, to environmental services for remediation of the lead hazards in their home, and social welfare services. And so that's their primary mission, and then they evaluate, how well they do that. So that's a model for consideration. Can I have the next slide? So in the case of the registry, the attacks resulted in both environmental exposures to the dust, the debris, indoor dust, ambient dust on the outside, exposure to traumatic events, injury hazards, and this was over periods of months until the summer of 2005 when the recovery effort was completed. And many of our enrollees also evacuated their homes. They lost family members, co-workers, they lost friends. These are all populations that you're thinking about as well. And the aims of the registry, more formally, were to, next slide, we want to understand the health effects of 9/11. We want to understand gaps in care, try to address them, and other consequences of disasters that could be early retirement due to health reasons, job loss, social isolation, and so forth. So we have built into the registry, baked in, is this pillar of responding to health needs and concerns. And we also have a team dedicated to aim 3, was just maintaining an updated registry. We're only as good as our ability to reach our enrollees, and we have to constantly work to keep the contact information updated. So we have what we call a panel maintenance team. 5 people do nothing but that. And we aim to inform the World Trade Center Health Program, healthcare in general, and any future disaster preparedness and response efforts. So let me talk to you about the registry creation. And there's an interesting thing I wanted to mention. Shortly after 9/11, it was before I arrived at the health department, there was a conception of developing a registry. And one of the elements why they considered a registry was to try to manage the burden of research on people who are exposed. We're in New York City, a lot of academic institutions. They knew there was going to be a lot of interest in reaching out to people to enroll them in various research studies to learn about health impacts. So that was part of the thinking behind it. But in 2002, we received federal funding, which was key to establish what they called an exposure registry. And it was designed to last for decades, and indeed has lasted for decades. And the recruitment, we can come back to this. It's a long story. There's a lot to say here, but basically 2 approaches. We gathered lists of people who were potentially eligible. We worked with a vendor, and we did extensive outreach through subway ads, bus ads, public service announcements, direct outreach to police stations and firehouses and so forth. And over a period of about a year and a half, enrolled 71,000 people. They voluntarily enrolled in the registry, and they took our initial health interview that covered their exposures, health history, and experiences on 9/11. And so this registry became one of the largest efforts in the US to track people following a disaster. So who's in the registry? Let's take a moment to look at that. I think you'll see there's some overlap in, if you envision a registry, post October 7th, you may have some similar groupings of people. Our largest group were people who worked in Lower Manhattan, area workers, people who were passing by in Lower Manhattan. We also have rescue recovery workers and volunteers. We have people who lived in Lower Manhattan and children and staff of schools in Lower Manhattan. And, we could envision, I know that you're thinking about occupants of communities that were directly impacted, people who evacuated their communities, people who are injured, children, I know are of interest. So the point is that here, registry is a blend of multiple populations that were thought to be highly exposed to the 9/11 disaster. And you can see for the numbers that 400,000 people were estimated to have been exposed, and we have close to 20% of that number, but the coverage differs by group. So for the rescue recovery workers, we have about 1 in 3, and for the residents, we have 1 in 4, and children in schools, close to 1 in 5. So it's a very large registry. People did not need to be ill. They needed to be exposed. And we have overlapping exposure groups. So in many cases, the area workers, people who worked in Lower Manhattan, also lived in Lower Manhattan as well. So can I have the next slide? And maybe another similarity is, with the 9/11 affected everyone in the US. And in the case of our registry, we have enrollees from every state and virtually every congressional district, which help build political support. And the reason we have people from every state is that, for example, rescue recovery crews arrived in New York City from all over the country. It also reflects people from all over the world and all over the United States who were in Lower Manhattan at the time of 9/11. And then within these groups of responders and civilian survivors that we have, they're very diverse groups. So I just wanted to show you some of them to give you an idea of the diversity. that includes, many vulnerable groups as well. So let's look at the next slide. So on the rescue recovery worker side, we have volunteers that worked for the Red Cross and other organizations, and sometimes just people who jumped in to help. They had no training, no prior experience. We have very highly exposed workers who were on the debris pile, on 9/11 and the ensuing weeks. We have thousands of New York City firefighters and police officers. And then we have thousands of Department of Sanitation workers. And here's an example of a group of workers who are vulnerable because they're not your traditional responders. They had no prior disaster experience, training, and things like that. So that's a vulnerable group. And then on the civilian survivor side, we had a lot of people that evacuated buildings in Lower Manhattan, including the Twin Towers. We have 4,000 people that survived the Twin Towers, but many, many people evacuated their homes in Lower Manhattan for varying amounts of time. And we have non-English speakers who chose to complete our surveys in Chinese or Spanish language. We also have other languages, and we have people who were pregnant at the time of 9/11 as well. So there are other groups. We have low income, vulnerable groups. So we have people who experienced injuries on the day of 9/11. So there are a lot of vulnerabilities here, a lot of overlapping exposures and experiences. So let's focus a little bit on some of the high exposures or more prevalent exposures on the next slide. So more than half the people in our registry witnessed at least one traumatic event. We asked about, fortunately seeing people jumping from the towers, the collapse of the towers, people were injured or killed, that sort of thing. Almost half of our enrollees were caught in the dust and debris cloud that resulted from the collapse of the Twin Towers. And then we, have high percentages who evacuated their buildings, evacuated the home, or worked on the debris pile. Thousands were also injured. Can I have the next slide? So I mentioned earlier that we get periodic health updates. And in developing the surveys, we get input from our community advisors. We have labor advisors because they're very involved in workers in New York City. We have scientific advisors. So we develop these surveys. Since the initial wave 1, the enrollment, we've had 4 follow-up surveys. We have the wave 6, 24 years post 9/11, planned for launch in April of 2025. And the response rates to the surveys are very good for a large longitudinal study. And we have tens of thousands of people at this point who've taken every survey or every survey but 1 or 2. So very, very large number of people with a high propensity to respond to the surveys. And in between our survey waves, we're also busy doing some more focused surveys. If I could have the next slide. So we're either focused on a particular subgroup, like the Staten Island landfill and barge workers. They were very severely affected because they were kind of hidden from public view. They weren't getting the support from the public that the workers downtown were getting. So we did a follow-up with them. There are particular health issues that are potential emerging conditions like autoimmune diseases. We had an interest in finding out what happened to people who had injuries on 9/11. What was their course of recovery? How are they functioning? And we also looked at early exit from the labor force due to health reasons. And 2 of our surveys, the Hurricane Sandy and the COVID surveys in more recent years, we focused on subsequent disasters in New York City. So this is positioning us to begin to understand better the impacts of multiple disaster experiences on people that have experienced 9/11. And I think that may be something I think very relevant for the situation you're dealing with. Can I have the next slide? Okay, we've been at this a long time, and I don't want to read everything here, but I just thought you'd like to see that the breadth of outcomes and topics that we have been able to look at with regard to physical and mental health. I know you're most focused on mental health. And so I think I just wanted you to sort of glance through these and see, I think, many areas of interest that you have in the substance use, PTSD, depression, psychological distress. We've had focus on adolescent mental health, behavioral problems, school issues, functioning, and now major interest in early cognitive impairment among our enrollees. And then some of these other topics I think may resonate with you as well: the unmet healthcare needs, hospitalizations, neighborhood displacement and home evacuation, and social isolation and support. And this that's such an important factor, in understanding the experiences of our enrollees. High social support is a buffering, and social, isolation just exacerbates everything, and can happen as a result of exposure. And it's an area that's, I think, open for, intervention in this area. Okay, let's move on. I just want to spend a couple slides, very quick, high-level overview of our findings. And in a nutshell, we have documented both short and long-term impacts. It's on physical health, mental health, health behaviors, quality of life, functioning. And the outcomes are very similar among responders and civilians, although you may argue that some of the responders, may have had the very highest exposures. And some of our most common 9/11 related outcomes on the respiratory side: asthma, gastroesophageal reflux disease, rhinosinusitis, PTSD, depression, distress. There's also sleep disorders, are very common. And I would say a hallmark of our 9/11 outcomes is the co-occurrence of these comorbidity, or the co-occurrence of these conditions in any one individual is very common. So and the more comorbidity there is, the greater the impact on everything: quality of life, functioning, perceived health, unmet healthcare needs, you name it. And of course, we've learned, unfortunately, and despite our efforts and the city's efforts, some enrollees still have unmet healthcare needs decades after 9/11. And another comment about the comorbidity: it can come in different forms and different stripes. Sometimes it's multiple physical comorbidities like asthma and gastroesophageal reflux and rhinosinusitis together. Sometimes it's a series of mental health conditions, PTSD, occurring commonly with depression and distress. And then it could be a mix of physical and health as well. And then just a note on the next slide, because I know some of you are focused on children. We have over 3,000 people who were children at the time of 9/11 in our registry. But the findings are similar types of outcomes: the elevated occurrence of asthma and PTSD symptoms, the behavioral problems, school problems, increased risk of substance use. And a couple of interesting findings here is that the pregnant women at the time of 9/11 who had PTSD had a higher risk of low birth weight and preterm deliveries. And the children of parents with 9/11 related PTSD, maybe responders, for example, were more likely to have PTSD symptoms themselves than other children. So there's this sort of transmission, to family members as well. Okay, so while we're on PTSD, and I know Rebecca Rosen spoke to you about this, and Sandra Lowe, but I just thought just to give a snapshot among residents of the picture that you can get through a longitudinal registry. So this is the trajectories of PTSD from wave 1 through wave 4, 2015, 2016 in our registry. And it just highlights some, what many studies find is that most people do not develop PTSD. That's our low stable group, 72%. But on the other hand, there's a very high burden of PTSD, of about 1 in 4, a little bit more. And within that, we see there's 5.5% of people that have high chronic PTSD across the reporting waves. Some people have increasing patterns, some people have decreasing patterns, but there's a heavy burden of PTSD, not to mention all the other comorbidities going on here. And I think it was mentioned earlier, one of you in your comments, that this longer course of PTSD is also affected by everything else going on. So subsequent traumas, life events, disasters. And we learned that one of the main factors that's contributing to the persistence of PTSD is job loss due to 9/11. And there was a recent study by, I think, Yuval Nerea, based on a sample of adults in Israel, that reported like 31% PTSD within the first month. So, we can envision some type of registry post October 7th that would fill this picture in, that would give you, an early picture, a way to advocate for resources, a way to have early intervention, and a way to understand the longer term course. And maybe somebody mentioned, understanding the benefits of treatments, maybe through this longitudinal data on individuals, that you can also learn something about the benefits of some of the treatment modalities. Next slide. So given this heavy burden, again, this pillar of the registry, it's so important to us. We do participate in long-term disaster response, and we think that's a very critical function for a post-disaster registry, even though we don't provide the direct care ourselves. So the main way that we do this is through a treatment referral outreach. We have a dedicated team, mostly staffed by social workers, who can do outreach in multiple languages, and they are trained in motivational interviewing to address the perceived barriers. So you may be familiar with these, but some people are worried about the stigma of having a mental health condition and let others knowing about it. Some people don't connect their symptoms to the 9/11 disaster. We have many people who have PTSD and depression, and you can imagine the challenge in motivating them to go ahead and put in an application to the World Trade Center Health Program, because people with PTSD are isolated, and it's difficult to motivate them. So we have this dedicated team. They do individualized outreach based on people's survey answers. And so we have multiple rounds of this. Each time we do a survey wave, we follow up with thousands of enrollees to try to link them in. And when they need help, we help them apply. And there's a very special provision. The federal government accepts our Wave 1 survey answers to help support people's application to document their presence based on their answers to our survey questions on their day of 9/11 experiences. So we're actually able to help another barrier. And, healthcare utilization post-disaster tends to be low, and it's due to individual perceived factors and to systemic factors. So, we can help address some of the individual factors here, and also some of the systemic factors by actually providing documentation that can help them to prove eligibility for the program. We do other things to promote health. We've had multiple rounds of smoking cessation interventions over time. We actually work with our colleagues in the other 9/11 cohorts and develop physician guidelines for healthcare workers taking care of people who were exposed to 9/11. And they very much emphasize the need for integrated physical mental health care. And we produce those and disseminate those guidelines, and we update them and disseminate them to all physicians in New York City, and then they get posted and available to physicians nationwide. And I think we also send them to our enrollees, and we develop health materials on topics of interest to the enrollees as well. And we also have a medical director who can respond directly to enrollees when they contact us about their health concerns. Okay, so I have a next slide is just a word about the World Trade Center Health Program, because I wasn't sure everybody knew the basics. So this is just the basics, that the program was established by Congress in 2010. It became effective in 2011. It serves both responders and civilian survivors. And the legislation that created this program also created our registry. So somebody asked about the political, how this gets established. So support for our registry 10 years later was written in to a piece of national legislation called the Zadroga Act. And it doesn't say that it's an earmark for us. We have to submit a grant application every 5 years, but there shall be an entity, is what the law says, of a registry. But the program does cover 9/11 covered conditions, and people get services in these centers of excellence in New York. You are familiar with Mount Sinai, for example. There are others, and then there's a national provider network serving survivors and responders all across the country. And then there's some differences in who's eligible and how they're eligible. But the one main difference is the civilian survivors need to have symptoms and conditions to be eligible, whereas the responders don't. They can be eligible, join the program, and get some monitoring as well. And there's a very high coverage of the rescue recovery workers, but less so among civilian survivors because they just don't know about it. They may not have the support of the labor unions to get them informed and motivated to apply. So next, I just want to mention a few other ways on the next slide that we keep our enrollees engaged, because we're only as good as our ability to keep people engaged. So we have periodic newsletters and e-newsletters. We have a website where we provide findings and resource information. We make our own brief videos about our findings, and we have enrollee testimonials. They're just like a minute in length. We give our enrollees the ability to update us on their contact information, lots of different ways. And we also do outreach to boost response to our surveys with a particular focus on some of the under-responding groups. You may not know it, but residents of Lower Manhattan are an under-responding group, right? And then there's certain demographic groups or people who don't speak English as the first language. So we have some targeted equity outreach for that. All right, I want to come back to something I mentioned earlier about the registry being a platform for external research. And the main thing here is we do a lot of work with in-house scientists, but this platform, which is, we've approved dozens of studies over the years, they really extend what we do. They bring in collaborators that are very fruitful. Sometimes they're independent studies, sometimes we join. But I just listed some of the topics of these approved external studies where the recruitment was facilitated by the registry for the external researcher. Because I think these topics are of interest to you. There's prolonged grief study now, where we've enrolled close to 1,000 enrollees in our study. There's studies focused on mental health service need and use among youth, PTSD and police. I think, Michal, you mentioned treatment. What are we learning about treatment? Well, we have had a clinical trial of treatment, of drug treatment for people who have PTSD and alcohol use disorders. And there were some studies that looked at the process of evacuation from buildings. Okay, so we're nearing the end. I just wanted to highlight some next steps. I mentioned that we're going to launch the Wave 6 survey. And there's some ongoing studies here I've listed because, again, it might resonate with some of your topic areas of interest. We're doing a qualitative study of multiple disaster experiences with our enrollees. We have the study of prolonged grief that we want to finish. Our medical director is very interested in post-traumatic growth, where the disaster experience can actually result in positive psychological growth, maybe change people's outlook, become more resilient. So we have gotten some information. We're going to do a follow-up survey that's launching in October. And then we have, the median age of people in the registry now is over 60. And so we have an aging cohort. And there's a lot of interest in aging, and there's some evidence people are concerned about of early evidence of cognitive decline among both survivors and enrollees. So we're gonna launch a special study looking at this that we're hoping will include in-person cognitive testing over time. And then I had mentioned that, we could be a platform for intervention studies, and we had done one based on emergency preparedness that we're hoping to finish up. And we do have an interest to linking to additional external sources of health data. It becomes very important as we have attrition, people drop from the registry, that we're able to link to other data sources to fill in health information if they're not taking our periodic health surveys. Okay, and then next, Bruce asked a question about why should we keep this registry going? So Bruce, I want to answer your question. We want to continue looking at the life course of 9/11 conditions. We want to identify new emerging conditions. I mentioned there's some cancers people are concerned about, cognitive decline, pulmonary fibrosis. There's a lot of things, and we potentially would be in a position to assess next generation impacts. So to enroll the children of our enrollees is something of interest. We still need to and want to promote 9/11 healthcare access. We want to understand better multiple disaster impacts, inform healthcare and disaster preparedness, and we want to be a resource for other registry and cohort studies. We do hear from people all over the world. Most recently, it was people in Hawaii who are trying to establish a registry following the Maui wildfires. We've heard from people from South Korea, from Japan, from Flint, from Michigan, from the Horizon oil spills. So we're just kind of on the radar of people in the public health world, and we like to be able to help. And in fact, we have a forum where we gather people from various longitudinal and post-disaster studies to talk about how to do this work, how to keep people engaged, what works, what are the best practices, and you all are welcome to join if you like. And let me end with just some few lessons learned, and some of them are really lessons learned for registry, and some are beyond that, but it's very important.
Mark,
Yeah.
So let's make this the last slide so we have enough time for comments and questions, because we've had a series of places where we thought it was the last slide. So let's wrap it up.
Okay, sorry. So this is the last one. It's important to establish early on, and you still have the ability to do that. Dedicated long-term funding is really important. The integration of physical and mental health care. It takes an active step to connect people to care and compensation, and looking beyond the current disaster and looking beyond just health to other impacts of disasters, and then taking into account additional disaster experiences. And that's very relevant for your situation. So I'll stop there.
That's great. So let's stop the sharing. And Mark, first of all, thank you. That was a very clear and interesting presentation. And I'm going to ask the first question. You know our situation in Israel. You've spent time in Israel. You come back regularly. You know what the disaster was that we faced. You know the way our health system is set up. If we were to do something like this, how much of it would you have us rely on the information that the health plans collect anyway from their people, from the members, and how much is it so important to do special surveys or special things?
Yeah, no, I think maybe you're at an advantage given the structure of the healthcare system if you're able to get cooperation and pull that information. But I think it will require additional activities to, number one, maintain a cohort. Okay, you have to communicate with people on a regular basis. You have to know how to reach them. You have to offer them information that's going to keep them involved. And
but what do you learn from the surveys that you can't pull out of the medical record? Is my basically.
Well, we learn, one, about their disaster experiences. Okay. We learn about subsequent traumas and life events that are very important to take into account. We, we learn about social support. I don't know if that's going to be in your thing. We learn about social isolation. We learn about impacts on work. We learn about early retirement. We learn about economic impacts of the disaster as a result of
Okay,
things, right?
you've convinced me. It's clear that it's not all health. It's a lot of it is social and employment and economic, and it's bringing it all together. So thank you.
Bruce,
Who
how
else
can
would
you
like?
ask that after coming back from a tour with me? And it's not only health.
I know, it's just there was a few months ago, so some of that Shlomit effect is
Got that.
worn off.
Right. But also there's this added value of qualitative research, doing focus groups to better understand people's experiences. You have an interest in getting people into care, right? And learning about different modalities. You talked about, I think in your thing, that there may be different constellations of providers. So you can learn a lot about that by interviewing your enrollees about their experiences. It would help decide whether you want to launch into a new area or explore a potential emerging condition. But I think the voice of the people in the registry is really, really important.
I'm convinced.
Right?
Okay, who would like to ask another question or make another comment? Shlomit and then Michal.
How would you go about defining the denominator for the cohort studies or registry or whatever in Israel? Because it's all of Israel, but then we have the north and the south. And then if you just look to the north, okay, which is a bit more complicated, like research-wise, as opposed to the south, who are we talking about? People who are directly injured is easy, okay, but then where would you cut off, this, what is the second and third circle? What would you cut? Like, I don't even know how,
Yeah, no, it's a really important question. I think you just have to what do you envision? That was my question for you. And
I envision all the country, but I think that would be almost impossible.
Well, but you have an example of a registry here post 9/11 that has people from all across the country and has good coverage and good representation. You don't need everybody. And it depends on the focus. If the focus is, are you interested in a service-oriented registry like Flint, Michigan, where the main purpose is to share resources, connect people in, and then evaluate that effort? Is it a combination of service and research? Right? And then, you see the World Trade Center Health Registry does have multiple different populations. And I think that's the situation you're in. And I think that you may have ways to delineate the population, maybe even better than the situation here in New York at the time of 9/11 or afterwards, because you do have the Kupot, you have Bituach Leumi, that maybe you have the local councils. There must be rosters of people who lived in different communities that would be available. You could select on those. You got from Tzahal that, maybe a way to figure out who experienced an injury. I think you have to take each population and then tailor, elucidation of the denominator, and then also a way for recruitment as well.
Okay, that's helpful. We're going to take a question from Michal, and then I'm going to ask Yoel to share some comments from your unique perspective, even though you didn't raise your hand. Michal.
I think Gidi wanted to ask as well.
Yeah, but you go first.
Okay, so maybe I didn't understand you correctly, but I wanted first, when we were in New York, I thought that the research is only on the administrative data, like data that is taken from, getting checks and services. And now you say that you spread questionnaires, and then that you offer services to the ones that express needs to certain services. So I understand that the participants are not anonymous, and how
No.
they're not. And
No.
so how ethically, how does it, because in Israel, from an ethical point of view, it is very restricted that the participant would be anonymous. And another thing is how you combine administrative data with data that you collect via surveys.
Well, part of my advice is as soon as you can, think about the way to get your Helsinki Council, we call them IRB approval, to be in a position to at least develop a roster of people. You need to develop the roster of people who are potentially, going to be invited to join a registry, right? And this would be a volunteer registry. So 71,000 people voluntarily enrolled. They gave their permission, 1, to be contacted with periodic surveys, 2, to be invited to other 9/11 related studies that we might do or external researchers might do. They gave us permission that we could send them health materials and information. And when each survey, we preface the survey by saying that we may reach out to them based on their survey answers to try to share resources and connect them to care. So every 3 or 4 years before we do a major wave survey, we have a 1 or 2 page summary of rights that we mail to all of our enrollees, and it reminds them of all this information, of what they agreed to. And as we do more and more matching to administrative databases, if we match to any new sources, our IRB requires us to notify our enrollees through this summary of rights and alert them that we are going to be doing that and give them an opportunity to withdraw from that part of our activities. But we do meld our 5 waves of surveys with administrative data that we match to every couple years. And that's very, very important because we get more objective health outcome data that way, right?
Mm-hmm.
Cancer occurrences, deaths, right? So that's very important that we meld the 2 sources of data for our research.
Very good. Giddy?
Yeah, hi. 2 questions. One is if you ever checked what about the people who didn't volunteer, didn't enroll to your research? What about them? Is there any common any common things about them? And the other question is, in terms of policy, do you know now how to prevent all these phenomena that you learned about in the case of the next event?
Oh, wow. Okay, that's like hours of discussion. Okay, first of all, a feature of the registry that I need to mention is we had 2 avenues for recruitment. One was through list building and contacting people in lists, and the other was self-identification. So people saw our advertisements and called an 800 number or visited a website. So we have a predominance of people who self-identified, which you might expect to be people more likely to have symptoms and conditions, right? So there is that, but we have the ability to compare the 2 groups. And we also have the ability to compare people who are lesser exposed to people more exposed. We do not have an unexposed comparison. It was just with so many affected populations, it's very difficult to think how we might have done that. Although we do make comparisons to New York City and national data as well. And your other question about, like, I guess, are we better prepared for the next one? I hope so. I think there was a lesson learned about reducing exposure to rescue recovery workers, for example, as much as possible. We had a lot of people who were not wearing respirators or didn't have adequate respirators. There are measures, that lessons learned about restricting access to the disaster zone to avoid exposures, to minimize volunteers and non-professional rescue recovery workers who are very vulnerable, and have clearer instructions. There's a lot of anger here in New York City to this day in the community about they felt like they were not warned of the hazards by the local and federal government. They were allowed to come back to their homes and their offices when it wasn't safe. So I think there's some lessons learned about clearer communications from government, how people
Mark, I'm
can
going to hold you up there because we
Yeah.
only have a few minutes left. I want to hear from Yoel, and I'm expecting that you're going to come to Israel sometime in the next couple of years. And this is not going to be our last chance to hear from you. We're going to, one way or
Okay,
another, if
sounds
we do
good.
this, get you involved as some sort of advisor to us. Yoel, please.
Okay, just a couple of recommendations. The best recommendation that I can give is to learn from the experience of WTC in order to define very clearly what it is that you want to learn. I think that's the most important recommendation, because if you know what you want to learn, we'll take care of all the other technicalities. If we start worrying about the data, we're going to get the data, not going to get the data, administrative data, not administrative data, surveys, not surveys, subjective, objective. So that's the best recommendation, is to try and learn from the experience of 9/11 WTC, so we can define clearly what is it that we want to learn. Okay, that's number one. Number two, as far as the law is concerned, I know health is the problem because of Helsinki, but of course there may be different if we talk about volunteers. I'm not the legal advisor, but when you're talking about people who are volunteers, that solves many of the problems as far as the data is concerned. So that's also a very important point that we learned. One other recommendation, because we don't have much time, is that maybe if we want to understand more what we're looking for, we can start with maybe research. Through research, we'll also understand a little about the data that we have. And so it's sort of like trial and error, and that also can help. So if we're not really sure what is it that we want to learn, research is possible to do already today. In other words, we can combine data that we have, try and get from the health ministry some data. We have data at Bureau of Statistics. So we might be able to learn something from even basic research. But again, try to learn what WTC has done. So to find very clear that we want to learn, we'll take care of the data issues after that. I'm trying to be optimistic.
And yes. I see a very interesting note from Michal. With AI tools, maybe we don't have to define everything in advance. Okay, Mark, last wrap-up sentence or two, and then we'll thank everybody. And
I think you hit the nail on the head. It's more thinking about what's the orientation here. Is it service? Is it research? Is it a combination? What do you want to learn? What are the objectives? Then you get into the nitty-gritty of how to establish it. Where's the political support? But we should stay in touch. There's a lot to talk about. But when you get to the point where you want to move ahead, you're welcome also again to join our what we call the CLEAR Forum, where we get together with longitudinal cohorts all across the globe. We have about 12 or 13 to talk about how to make these things work. How do you engage enrollees? How do you maintain their interest in a longitudinal study over time? What are the best practices? How do you celebrate milestones? How do you trace and track people so that you can reach them?
This has been a very well-used hour. I think we learned even a lot of really important stuff just in the last 5 minutes. Thank you, everybody. Thank you to Mark, and I promise you there will be a continuation. Thank you very much.
Thank you so much. Thank you.
Thank you.
So long.